Welcome, everyone, and thanks for tuning in tonight. My name is Carla Southward, and I am the Senior Lead of Knowledge Translation at the Ontario Brain Institute. I'd like to let everyone know that this session is being recorded and it will be shared publicly. Everyone's video and microphone have been disabled, except for the panelists and moderator. We do have a chat box for you to submit questions, so please feel free to use this before or during the question and answer period. And now, I'd like to introduce the President and Scientific Director of the Ontario Brain Institute, Dr. Tom Mickelson.
Good evening, and thanks everybody for tuning in. So as Carla said, my name is Tom Mickelson. I'm the President and Scientific Director at the OBI. Before we get started, as is our custom, we're all calling in from different areas around the country and around the world. I'd like first to acknowledge that the land of which some of us call home is the traditional territory of the Anishinaabe, the Haudenosaunee, the Wendat, and the Mississauga of the Credit First Nation. It's always important, I think, to take a pause and at least reflect on that fact. You know, at the OBI, we say that there's a quote that goes around: if you want to go fast, go alone, but if you want to go far, go together. And the fact that we have such a diverse crowd here tonight is evidence of the power of that collective. So our vision at OBI is we want Ontario to become a world leader in research, commercialization, and care to the service of folks dealing with neurologic disorders. We realize that this collaborative team science approach between researchers and clinicians and industry and patients and their advocates to accelerate the discovery and provide better treatment and services for folks living with brain disorders. So that's so critical to everything that we do. At the OBI, we have 6 integrated networks that cover many different brain disorders and diseases across the lifespan. And we collect data because in biomedical research these days, data is the new currency. This allows us to actually look across different disorders, regardless of the label that some of the folks carry, and learn to understand individuals better, no matter what the name of their diagnosis. So tonight, we're presenting data from a collaboration that extends across 3 of our major research programs: the CPNet, which is focused on cerebral palsy; EPLink, which focuses on epilepsy; and POND, which stands for the Province of Ontario Neurodevelopmental Disorders Network. So this is the very first of the research studies that are done across these different disease themes with the same data collected across participants in the same way, and allowing the reuse of data from previous studies and sharing it and mixing it with the others using this centralized database that we call BrainCode. So this BrainCode platform is actually a space for researchers to share data in a privacy and regulatory compliant way while ensuring this privacy and security. So going together helps us find new ways of understanding these brain disorders that none could ever be achieved without the children and family members of the participants in our network. And I'm very happy that some of those are leading the discussion of this evening. We obviously have consent for the use of these data in a regulatory and privacy compliant way. So I certainly want to thank everyone who's participated in CPNet, EPLink, POND, or other programs. And when you agree to share the results with other researchers, you become part of something bigger, of course. This is something that's providing faster and better outcomes for folks like you and your family members. Discovery starts with you, and really all of our work is engineered and intended to service the community. So before you all fall asleep, it's not about listening to me, so let's get the show on the road. I want to introduce our moderator for tonight's seminar, who is Connie Putterman. She's a driven, longtime friend of OBI with a mission on our behalf, and this is terrific. She's a parent of a partner for POND, a research coordinator for family engagement and research at the Center for Addiction and Mental Health, and a co-developer and co-instructor of CanChild's Family Engagement in Research course. So that's a lot of credentials, and we just really rely on her expertise and her input and her driven mission. So thank you, Connie, for moderating tonight. And and thank you to the panelists that are going to be part of the talks tonight as well. Each are experts in their field, and they've come together to collaborate on this research study for the greater good. So Connie, over to you. Thank you very much.
Well, thank you so much, Tom, for that warm introduction. And it is true, I wear a lot of hats, and particularly, all the number of years I've been on the POND Family Advisory Committee. So I really appreciate this way in which all the panel members and all of the researchers and people that are participating in OBI come together and share data and are able to do a study like this one. So before I introduce and set up the evening for tonight, I just wanted to give you a little bit of background about me and my relationship to sleep. So as Tom mentioned, I'm a parent of of two children, one who was diagnosed with autism 20 years ago, and which was a long time ago, and he was a young one at the time. He was 2 years old. So I think that our issues with sleep go so far back that I really had to dig deep to think about it. And I still believe that I'm feeling some of the effects of the lack of sleep that our family experienced in those early years with both our kids, but particularly the one diagnosed with autism. I thought of something kind of funny there, that we used to play a lot of music, and to this day, I cannot listen to certain musical artists like Andre Bocelli and the Carpenters, because we used that music all the time in our ways to soothe our child to sleep. And that now when I hear it, I get a little bit of the shivers, but it certainly at the time, it was one of our tools that we used. The other things that we did when I was sleep deprived, I remember I spent a lot of time listening to Dr. Ferber. Maybe some of you have heard that name from a long time ago, and I'm sure our panelists are familiar. And I even went to lectures that he was doing in person way back then. I was really desperate for information. But fast forward, I was now telling my family about this panel and about sleep. And I asked my son, well, what do you think of some of the things that I should reflect on in talking about sleep and how it impacted us? And he had a really great response. He said, Mom, I've got lessons learned for you. But before I do, I want you to say that I want you to talk about the fact that we should not move into standard time. We should always be in standard time. And so he gave me a mini lecture, but then he said, but you know, I have lessons learned. And three of my lessons learned are that I've imposed a very strict bedtime routine on myself, and that it's self-imposed, and that you should tell them that I've insisting on that strict routine. And that the things that I've done over the years is develop strategies for falling asleep and slowing my brain down. And he said that those strategies were distractions because I had a fear of falling asleep. And I use those distractions to this day. And that's what helped me fall asleep. And he said those same strategies helped me to really slow my brain down. So those are some of my reflections and his lessons learned on sleep. But what I really want to do is ask our experts tonight who have come together to tell you about the work that they've done in trying to understand sleep and its impact on mental health. So I'd like to introduce you to our esteemed panel. We've got Dr. Patrick McPhee, who's a postdoctoral fellow in the Department of Pediatrics at McMaster University, and he's an investigator at CPNet, which is OBI's Cerebral Palsy program. We've got Dr. Andrea Andrade, and she is a pediatric neurologist and epileptologist at the Children's Hospital in the London's Health Science Centre, and she's an investigator at Epilink, OBI's epilepsy program. We've also have Dr. Stelios Georgiadis, McMaster Children's Hospital Chair in Autism and Neurodevelopment, and he's an investigator at POND, OBI's Neurodevelopmental Disorders program. And last but not least, Dr. Penny Corkum, who's a registered child psychologist and professor at Dalhousie University. And Penny is also the principal investigator of Better Nights, Better Days, an e-health program that helps parents to help their children sleep better. So what I'm going to do, Patrick's going to give us a synopsis of the study and its findings, and Andrea, Stellulos, and Penny will give their lens on the findings from all of their individual perspectives. And I want to just frame the conversation tonight by putting in all the panelists' minds as you're talking, that what is it about this study that's exciting you? So what does it mean to you and what's exciting about it? But also, what does it mean for the future of future research in sleep, in interventions, in clinical care and practice, and in policymaking? So I want the panelists and as well you attendees to think about these issues as our panelists are talking. So I'm going to turn it over now to Patrick, who's going to give us a synopsis of the study and its findings. Over to you, Patrick.
Fantastic. Thank you kindly for the introduction, Connie, and thank you as well for sharing your perspective and experience as a parent of a child with sleep issues. And it was great to hear some of those self-imposed behaviors that your son has learned to figure out over the years to help him sleep better. So I'd also ask the panelists to keep that and the audience in mind as we work through these results and get into the discussions later on. So I'm very excited to be here this evening to share with you findings from a collaboration between 3 research programs within the Ontario Brain Institute, which investigated sleep, mental health, which will be referred to as symptoms of anxiety and depression, and health-related quality of life in children with neurodevelopmental disorders. And throughout this presentation, I'll abbreviate neurodevelopmental disorders as NDDs. Before I speak to the findings in detail, I'd like to start off here with a brief background regarding sleep and sleep problems in children with NDDs, as well as identifying knowledge gaps in research that this study helped address. So it's well known to many that sleep is a critical biological function that is important for recovery, energy conservation, and survival. And for children, it's especially important for growth and development. Whether or not an individual is a child, a teen, or an adult, there is strong evidence to support that poor sleep quality has detrimental consequences for attention, behavior and mood, quality of life, and mental health, as well as an increased risk for developing cardiovascular disease. Importantly, and as it relates to the focus of this study, the prevalence or rates of problems of sleep problems in children with NDDs have been reported to be as high as 86%. And these sleep problems include, but are not limited to, bedtime resistance, frequent night wakings, waking too early in the morning, as well as sleepiness throughout the day. However, key knowledge gaps exist and really limit our ability to understand and to treat sleep problems in children both within and across disorders. Particularly, our knowledge of these sleep problems in children with NDDs has largely been limited to studying one diagnostic group or condition at a time, or what I refer to here at the bottom of the slide as researching in silos. Because of this, most sleep behavior research involving clinical populations, particularly children with different NDDs, cite small sample size as a main limitation of their findings. And this really means that we don't know for certain if the findings apply to all children with a particular condition or conditions. In addition to this, inter or between study differences in measurement tools, different data processing methods, and statistical analyses, they can lead to conflicting or inconclusive results. So this study today that I'm presenting is highly valuable considering it collected data using the same measurement tools across 3 different programs to really further our understanding of sleep in children with NDDs. Next slide, please. So I share here the objectives of this study, which I want to point out was a cross-sectional study design, which means that all data were collected at a single time point. The first objective was to determine the rates of sleep disturbances or problems in children with different NDDs compared to typically developing children. The NDDs in this study included attention deficit hyperactivity disorder, or ADHD, autism spectrum disorder, cerebral palsy, epilepsy, intellectual disability, and obsessive compulsive disorder. The second objective was to understand differences in severity of disorder, quality of life, and symptoms of anxiety and depression in children with NDDs above and below the clinical cutoff for sleep disturbances. And I just want to take a moment to elaborate exactly what that means. So we used a questionnaire called the Children's Sleep Habits Questionnaire to measure sleep disturbances. There's a total threshold or clinical cutoff score to determine pediatric sleep disorders. So for this objective, we separated children with NDDs above and below this cutoff and looked for differences between the two groups. And lastly, the third objective was to examine the relationships between sleep disturbances, symptoms of anxiety and depression, and quality of life in children with NDDs. Next slide, please. Next slide. So I'm going to highlight the key findings here. So in total, we had 1,438 children with NDDs that met our inclusion criteria, which were rather brief and included children aged 4 to 12 years old with a primary diagnosis of one of the 6 disorders I previously mentioned, which are also highlighted or displayed here in individual blue boxes. There were also 140 typically developing children recruited and tested and included in this analysis as age-matched comparison group. In the bottom half of this slide here is really just a basic presentation of the results comparing sleep disturbances in children with NDDs to their typically developing counterparts. We see here that compared to typically developing children, children with NDDs had increased disturbances related to resisting bedtime, night wakings, sleep onset delay or more time required to fall asleep, daytime sleepiness, poor sleep duration, parasomnias or night terrors, sleep disordered breathing, and sleep anxiety. And together, children with NDDs had significantly greater total sleep disturbances compared to typically developing children. Next slide, please. So this is a rather simple diagram, but what we want to show here is that we found for children with NDDs, those with greater severity of disorder, they were more likely to report total sleep disturbances above that clinical cutoff than those with lower severity. Next slide, please. But interestingly, we found both children with NDDs and typically developing children with sleep disturbances above the clinical cutoff. They reported lower quality of life scores and increased symptoms of anxiety and depression. But importantly to note here is that these relationships were found to be stronger in children with NDDs. Next slide, please. So these are the key messages or key takeaways from this study. So the first one being that we need to look really beyond the diagnosis to understand and to treat sleep problems. And Dr. Mickelson alluded to this at the introduction to this webinar. There are many commonalities among disorders regarding sleep problems or disturbances. And these findings really identify a common starting point or foundation for treating sleep in children with NDDs. The second point here, our findings show that greater sleep disturbances are problematic for all children, including typically developing children, but particularly among those with NDDs. Our study showed that 79% of children with NDDs had sleep disturbances, which is comparable to what we know from other research studies. But these are really the first findings to show these rates of sleep disturbances in a large sample of over 1,400 children with different disorders. The third point here, severity of disorder was associated with greater sleep disturbances. If I can link back to my first comment about a common starting point or foundation for treating sleep in children with NDDs, regardless of disorder, these findings would add a layer to this foundation such that disorder-specific symptoms or severity should be incorporated into treatment programs. And finally, the last point here is that sleep disturbances were related to symptoms of anxiety and depression and lower quality of life in all children. However, again, these relationships were stronger in children with NDDs, and that's what we observed from this study. That really sums it up. So back over to you, Connie.
Yeah, well, thank you, Patrick, for that and giving really the highlights of the study and the overview. So I have, a couple of questions I want to unpack. I'm wanting to know that you mentioned that sleep problems are common among children with NDDs and that are greater amongst children with NDDs, but what about across disorders? Were there any differences across disorders, and did your data particularly look at that?
Yeah, so that's a very important question. I'm sure people in the audience are curious about that as well. And thanks for asking that. So we did find some differences between different NDDs. So for example, we saw that children with ADHD, autism, and obsessive compulsive disorder, they had greater problems with sleep duration and sleep onset delay or trouble falling asleep compared to children with cerebral palsy. But for other sleep domains, including bedtime resistance, sleep anxiety, night wakings, parasomnias or night terrors, and sleep disorder breathing, there were no differences between the different disorders. So again, the main message here is that the commonalities amongst disorders, as well as children with NDDs having, again, greater sleep disturbances than their typically developing counterparts.
And what does this mean, Patrick? Like, and where do we go from here with that information as we parents, intuitively know what this research is showing? Like, we intuitively know our kids with NDD have a harder time falling asleep, but what does it really mean? And how do we go from here? Why is it significant? And also, why was really the approach to this research really significant as well, which I think you touched upon?
Yeah, so again, the large sample size is one factor that's somewhat novel to this work, but again, highlighting the commonalities across disorders. And I think parents and families of children with NDDs can also acknowledge that they're not alone. So we're seeing these difficulties and disorders across the NDDs. And really what this means going forward is, support for interventions that can target and improve these sleep issues that are inclusive of all disorders, but also, again, that added layer of modular or tailored, in the sense that disordered specific symptoms can still be addressed and managed. And I know Dr. Corkum will speak to this a little bit more later on, but along the lines of interventions and next steps, I think this really provides a nice foundation and framework to build on in terms of designing interventions, the accessibility of them, as well as implementing them both in clinical care and in research.
So when you say, for example, like if you have a similar intervention to start, but then in treating diagnostic specific NDDs, you would include specific criteria based on the specific diagnosis.
Yeah, so that's kind of the added layer that I was mentioning. So, there's research that shows that even interventions that have been performed in typically developing children, they're translatable to children with NDDs. Now, it doesn't work for everyone. I'm aware of that, but that foundation or starting point in terms of, healthy sleep practices and trying those sort of behavioral interventions that I think you alluded to, Connie, at the beginning around, your son implementing that strict bedtime or distracting himself to help it fall asleep. Those are, kind of common behavioral things that can be a good starting point for everyone. And then adding that next layer of symptom specific targets, whether it be, rigidity or fidgeting, things like that, or arousal that may be unique to certain disorders. That's sort of that extra layer, the next layer to target on there.
Yeah, that's really, really amazing. As I know, in those early days, there wasn't, and to my knowledge, there never was any opportunity to look at sleep as part of an intervention strategy. So this is really exciting. I'd like to really thank you, Patrick, and call upon Andrea to give us her perspective on the findings and what they mean to you, Andrea, coming from as a pediatric neurologist. What does that mean to you? What does this mean to you?
Thank you, Connie, and thank you, Patrick, for the great presentation and also for setting the stage and for sharing your story, Connie. That I think that was very inspiring. And also I want to say that when I got invited to participate in this study, it was really exciting to me because as a clinician, I deal with patients with NDDs like every day in my clinical practice. And although I'm specifically, my main area of expertise is epilepsy, many of my patients also have other comorbidities. And sometimes in one patient with epilepsy, I can have also autism spectrum, ADHD, intellectual disabilities, and so on and so forth. So this is a constant problem that my patients and my families encounter, and definitely I can see in the individual basis and in the family basis how this affects quality of life. So to me, the fact that as researchers, as experts in our own areas came together to look to the NDDs as a group, as opposed to in our individual silos, it's quite meaningful. I think this can translate in not only showing what we already knew, that is that this population has way more severe sleep issues, and that the sleep issues affect their quality of life and affect, of course, their mental health. But this will provide us the opportunity to bring our results to a larger audience, or to a larger group of stakeholders, and put together a more comprehensive multidisciplinary teams that could approach this group as a whole, as opposed to me working in my little clinic in London, Penny working in Halifax, and so on. So I think to me this is just the starting of a very exciting set of possibilities in terms of accessibility, intervention, and showing our results to policymakers, perhaps to provide more resources to the families that we treat.
Yeah, and as you say, I think it is a it's a beginning stage of setting the stage for the idea of an inclusive approach to tackling sleep issues. I guess what I really want to try and understand, and maybe I'm going to turn to Stelios for this question, is as a researcher in children. So thank you very much, Andrea, for that perspective, coming as a clinician. But as a researcher, what do you take from this study? And maybe you can talk a little bit about severity. I'm thinking about what does it mean, like, as what the impact of severity have on sleep, and does it mean that, and also to clarify the question, does it mean that all children who are diagnosed with an NDD have sleep issues? And does it mean that in Patrick's graphs, if people who have the more severe the condition, the most severe your sleeping issues? Maybe you can talk to some of that.
Yeah, thanks, Connie, and thanks everyone for being here today. I'm going to echo some of the messages coming from Patrick and Andrea and yourself. This was really the first opportunity that we had as researchers to look at the data specifically related to sleep problems, mental health issues, and quality of life more holistically, moving away from the diagnostic silos that most of us are kind of used to working within. So one of the things that I take away is that sleep problems, as was noted, is a transdiagnostic issue. Having said that, that should not be interpreted that the interventions should be kind of a one size fits all. And Penny will provide more information on those interventions and how they can be personalized based on the different patterns of sleep issues in children. The other thing that I find very, very important here is that we now have empirical scientific evidence about the importance of A, studying sleep problems in our research, and B, making sure that we advocate using scientific evidence for the policies and programs for children across diagnostic categories that need services and supports. And the final point that I want to make is that with the leadership and support of the Ontario Brain Institute, many of our studies presented here today are continuing. Patrick noted that the data that we have here today is cross-sectional. So it's a snapshot of how sleep problems relate to health issues and quality of life. But we are continuing to gather data longitudinally. So we're following these children and youth over time. So the idea is to begin to understand how these patterns of sleep problems and their association with health and quality of life, how do they evolve? How do they change over time? And how do interventions actually help us get to the optimal outcomes that everyone wants?
So that's, I think that's exactly where and the goal of not only the research community, but as well, I think the parent community. That's what we do want. But I want to unpack a little bit of what you said. I think what I'm hearing is that based on this research, that there's a need to apply sleep interventions or sleep hygiene or good sleep hygiene for all kids at even a baseline level, and then as they develop or the severity of symptoms impacts their sleep, then it can be translated to specific interventions that meet some of those needs. So it sounds like it could be good for all, and that's how I'm trying to understand it. But I think that, Penny, I want to really turn it over to you as a psychologist and researcher and someone who has been able to demonstrate the impact or the translation of research into practical solutions. Perhaps you can give us your insights.
Yeah, no, thank you very much. And it's great listening to everybody's kind of take from the research results. I came into the study a little later and was really excited to be involved. And I think it's just wonderful to have such a large study with Canadian data. So we have data from other countries, but I don't think we have anything this large from Canada. So, and the results are really holding up. With children with neurodevelopmental disorders, about 80% or more will have sleep disorders. So that's pretty high. I was thinking as a psychologist, I've worked in the field for 22, 25 years. And I actually got interested in sleep through my work with children with neurodevelopmental disorders when I just noticed how huge of a problem this was for families. And then I don't know if this was just coincidence, but then I had my own family and my child who had significant sleep problems. And so I really was then even more encouraged to kind of find solutions and accessible solutions, because it's hard to find help. There's not many places you can go, and we know that healthcare providers are not trained very well in sleep. So, a lot of parents are suffering and don't know where to reach out. So my own work, I really wanted to make accessible interventions, and that's kind of where I came from in terms of my research and my clinical work. And I think that the research that Patrick shared really dovetailed nicely with the research that we're doing that shows exactly what everybody's saying about this transdiagnostic approach. what we call it is a modular transdiagnostic approach. So yes, there's core pieces that work. Sleep is biological, as Patrick said. There's going to be principles that work across all people of all ages, but those have to be modified based on some other factors. So the way we think of intervention for children with neurodevelopmental disorder is you have this core, and then you have a layer that is cross-cutting behaviors that impact sleep. So like anxiety or having a racing mind when you go to sleep, or a lot of stress in your daytime, that sort of daytime behaviors. And then we have a third layer, which is diagnostic specific. So, there are certain things that impact sleep that are related to a particular diagnosis. And so, for example, children with ADHD tend to be more, have their sleep shifted later at night. So they tend to be more of owls, and that can have this kind of impact on sleep. So we think of really these different layers. And I see that a slide was brought up. I'll just speak to this for a second. So regardless of who we're treating for insomnia, I'm talking about here, we always kind of follow the same best practice treatment. First, you have to start with other concerns. So let's think of it, a baby who has reflux. I mean, you're not going to be able to treat the sleep until you have addressed that other problem. So first, we want to make sure there's no other problems that we have to address. And then we want to share information, because sometimes there's just misinformation. A particular example that jumps out in my mind is thinking that it's not normal to wake up during the night. It actually is normal. What is problematic is if you can't self-soothe back to sleep. So we want to make sure that, good information's out there. And then we want to look at healthy sleep practices. So, and I'll go over those a little more detail, but making sure that everything's conducive for sleep, that we're setting ourselves up for good sleep. If that doesn't work, we move into behavioral strategies, which is using cognitive and behavioral and learning theory. And that's usually supported by a healthcare provider. And then if all of these don't work, we should turn to medication. This should be not common. But unfortunately, these days, what is happening is that most children, especially children with neurodevelopmental disorders, when they have sleep problems, are tried with medication right away before trying these other strategies. Yet we know these other strategies work, and they are the first line of treatment. So one of my other goals is to try to get out to everybody that we need to start. We need to follow this pyramid. We need to start with the basics, adding in the different strategies before we try medication. So long-winded answer to your question, Connie.
Yeah, I mean, these are really great, really like tips on how to address and treat insomnia. We did get a lot of questions from parents about, looking for tips in general, and I think this really covers that. I think what just came up on the slide too, that 15% of children with insomnia receive evidence-based treatment. Can you just explain what you mean there?
Yeah, so evidence-based treatment is just basically following this pyramid, starting at the bottom and working up. And so most children actually, like I said, receive treatment rather than the, starting with education and healthy sleep practices and behavioral strategies. Perhaps if we have a few minutes, if you could just click ahead in the slides, maybe the next one. Yeah, so healthy sleep practices is something I think we can all kind of work on. And these are foundational for everybody, for their sleep. And whenever I talk about sleep, I used to have a hard time remembering all the pieces. So one of my smart graduate students made this little acronym to help me remember, a mnemonic. And it's just the ABCs of sleeping. And so I thought I'd just share that with everybody here, because it is a way of kind of remembering what's important and the foundations that are important for sleep. So first of all, age appropriate bedtimes, wake times, and naps with consistency. So we need to sleep for the right amount of time at the right time of day. And we need to do that consistently from day to day, weekdays to weekends. So your son nailed like exactly what you have to do. You have to have a good routine in order to do that. It's so important. And I hear so many people say, well, you know, children with neurodevelopmental disorders don't need to sleep as long. That's not true. They do need to sleep as long. They have a hard time doing that, but they do need sleep, right? So those first few things are foundational, and we have found that just doing that alone can be so helpful for sleep. So if you just flip ahead one slide, I'll just show you from the National Sleep Foundation, there's recommendations about the sleep duration. And so you can just Google this and find it. But for a school age, elementary school age child, you're looking at 8 to 10 hours. So, you know, you really do have to try to target those ranges, and you want to see that they're waking up feeling rested and that they're going through the day feeling rested. So that's kind of the goal. And if you just go back the slide, please. Yeah, so inconsistency, this is a big issue, especially when you get into adolescence, when they stay up late at the weekend, but then not, you know, then they're trying to get to sleep during the weekday, and it's like jet lag, right? It's like going to you know, Paris for the weekend and coming back. It's just not, it's not going to be really good for sleeping. So we want to make those consistent between the weekdays and weekends, need those schedules and routines, and not just around bedtime. Our bodies like schedules and routines all the time, and that helps set the stage for good sleep. Location, we have to think about where we're sleeping. You know, we want a cool, dark room. We don't want a lot of noise. So, you know, even the environment can make a big difference. Electronics, this is a big one, especially these days. I think especially with COVID, our use of electronics has gone way up. It's problematic for two reasons. One is that it can stimulate and excite you, and so that's hard to sleep because you have to be calm to sleep. But also the blue light can be problematic. So we really recommend not having those in your bedroom at all, and not using them for an hour, at least an hour before bed. And then we have to do things during the day to really help us sleep better. So exercise and diet, eating well, getting exercise, not too close to the bedtime, but during the day, getting some positivity and relaxation in there. You don't want to go to sleep worried or wound up. You don't want to be roughhousing just before you go to sleep. You have to be in a relaxed mood. We need to learn to fall asleep independently. That's really important. Sometimes some different cultures that may not be something that is important, you know, or seen as, you know, the ideal situation. But what I would say is how a child falls asleep when they wake up for those little wake times during the night, which happens, which is normal. If it's not the same, they wake up all the way and yell. And so if you're laying down with your child when the child falls asleep, when they wake up at 2 in the morning and they check their environment, because this is a adaptive thing, and things have changed, that signals to them to wake up all the way and start to shout out, you know, figure out what's going on. So you have to keep those paired associations the same throughout the night. And then we have to make sure all the needs are met during the day. And really, if you do these, it sounds simple on paper, but having raised a child with a pretty significant sleep problem, I know they're not easy to do. They take a lot of effort. It's very easy to get off track with these, but if you can really prioritize these strategies, I think you'll see a difference in your child's sleep.
Yeah, those are really excellent, Penny. Thank you so much for that.
Yeah.
Now I really appreciate my son's comment when he said,
Oh,
why do we have to fall back to standard time? And he said, we have to eliminate daylight savings time. And I think it's a lot of what, because of the consistency and the scheduling and the, you know, rigorous routine that I know he's adopted for himself.
Which is great. And you know, Canadian Sleep Society is definitely always pushing to get rid of daylight savings time because it has pretty negative effect. We can look and see car accidents go up, like a lot of bad things happen because of time change, right? So
right. But that idea of routine and being self-imposed is a really interesting comment. But what I want to do is we've now got, I think, a number of questions that have come in through the chat, and I want to, turn it over to our audience and I will, Carla's going to give me some of those questions, and I will read them out and address the panel members. But one of the things that I also, think a lot about, and I've thought a lot about since I've joined this presentation, is really, the importance of this research and what it means when research like this is presented, and what does it mean for the future of besides really understanding sleep, but also the impact and translation of these understandings to actual practical things for parents. I think that's the exciting thing, and I think that's what our researchers and all presenters today have touched upon and really tried to convey. And so that's, with that in mind, I'm going to open it up to the questions and see what okay, so I have a question that's coming in from the chat. So the question is, who do I go to find out what the underlying issues are in my child's, why my nonverbal child cannot sleep? So does anybody in the panel want to take that question?
It's a tough question, and I think it really goes back to that we don't have a lot of sleep experts in Canada. I think there are definitely some physicians, some pediatricians, psychologists that do specialize in sleep. But if you go to the Canadian Sleep Society website, there is a list of sleep providers across Canada. And so I would suggest starting there to find people who are qualified to treat the sleep problem. I mean, I think that's the other challenge, is that because the training is not often part of healthcare provider training, many healthcare providers have to go get additional training. And so I think this Canadian Sleep Society website is really great because it vets the training of the people that they list. And so you can be pretty confident that they're well trained to treat sleep difficulties. There's some provinces have pediatric sleep clinics. Where I live in Atlantic Canada, we don't have any. And so that can be a real challenge, and families have to travel from Nova Scotia, for example, to Montreal or Toronto just to get a sleep study done. And so there's a lot of inequities across our country in terms of access to services.
Yeah, there's always those gaps, right? And we have to lots of things to be able to fill those gaps. I'm getting another question in the chat. Where does melatonin fit in? And it is I know that melatonin had been looked at, and was melatonin even considered in this study, for one, and has it been looked at as purely a treatment, or where does it fit? Who wants to take that one?
I mean, I can talk about from the clinician perspective, and melatonin has been used empirically by at least by pediatric neurologists and pediatricians to treat some minor sleep issues, especially sleep initiation in children, in our case with children with neurological conditions. There's some data supporting this fact. However, I totally agree with Penny in a sense that medications, even supplements, should be used not in isolation, but should be used also in conjunction with sleep hygiene and sleep habits significantly. So that's very important. And I think that comes back to the point that we need to approach sleep in a multidisciplinary fashion. So there should be, and after being part of this incredible study and collaborating with these very impressive experts, my feeling is that what we need is a group of different experts that can bring their point of view to the sleep issue, to specific neurological conditions, whether it's autism, epilepsy, or all combined, to really treat and see the problem from different lenses, and to try to accommodate and provide that multidisciplinary care. Because melatonin in isolation may help for a little bit, but if they don't do the sleep hygiene, it's just like a little Band-Aid. And I don't know if anybody wants to add to my point.
Yeah, I'll just add in that in terms of the Canadian Pediatric Society, they don't recommend using melatonin, right, as a first-line treatment, especially in healthy, typically developing children. We do want to try the other strategies first. It can be useful, but there's some issues with melatonin. One is that it's not regulated very well. So every brand and every dose, the quality of it's not necessarily consistent. So that can be a bit of a problem. So we have to be careful with that. It's many children with neurodevelopmental disorders particularly are on melatonin. We had a really hard time finding participants for our Better Nights, Better Days study that were not on melatonin. But many of them stopped melatonin after they started using some of these strategies and they got them working. So really, it's not that the research isn't showing a lot of adverse effects, but it hasn't been evaluated over the long term. So, we're still a little careful and we want to try other strategies first.
And what I've got another question, and it goes right into what you just said, Penny, that what do you do when those routines fail, or the routines don't work, the medication fails? Like what do you do when those things aren't working?
Yeah, I think you have to go back to the beginning and think of that triangle and have we ruled out, is there anything else that's causing the problems? Is there another underlying sleep disorder? Is there sleep apnea that might be impacting? Is there a physical health problem that might be impacting? So you really want to do a thorough assessment to make sure there's nothing else that you need to treat. And then I would say start to implement those strategies again in a very systematic, consistent way if there's nothing else that you have to deal with. Sometimes it just, especially for children with neurodevelopmental disorders, it does take a lot of repetitions for it to actually work, right? So this is what I find the difference as a psychologist treating typically developing or neurotypical children versus children with NDDs. A lot of it is the time it takes and the intensity of intervention. So for a typically developing child, I might, the parent might only have to do the routine 3 or 4 nights and it becomes habit. And for a child with an NDD, maybe they have to do that for a few weeks. And so sometimes it is just the persistence, which can be tiring and hard for sure.
Mm-hmm. Mm-hmm. I think that's really good advice. I mean, it does take continual persistence to get things to where you need them to be.
And I think the kids can fall off easier too, which is hard, right? Like, so I always think again, like of a neurotypical child, they get a toothache or a headache, and maybe that interrupts their sleep for a night or two, and you can get them back on pretty quickly, back onto the routine. But for a child with NDD, it might take quite a bit longer to get them back onto the routine. And so it's a lot of work. I mean, I know that, and you need the support. I think that's like a program like the Better Nights, Better Days program, does take it slower with families of children with NDD, just because we recognize that it's harder.
Yeah, and it actually, a couple things that come to mind too. I mean, one, as a parent, I can say that, you know, I had to dig deep for every aspect of patience that I could muster up to be able to go and do this over and over again. But I'm really encouraged by the study and the opportunity that this study presents in elevating the importance of sleep in children with NDDs, to elevate it so that we all can advocate for including and translating these findings for policymakers that are, or for interventionists who are going to include this, or researchers who will look at sleep as outcome measures for mental health, like that we see that in kids NDDs, that this could be this is a very significant measure of their future mental health and anxiety and depression. So I'm really excited about the findings and what they could mean in various aspects. I'm getting a couple of more questions in the chat. Somebody's asking, can entering stage 3 of non-REM or entering REM trigger a toddler to jolt awake?
Not typically. So I guess we're talking about like a parasomnia. Are they, I guess my question is, fully awake or just around, like, are they still like, so a night terror versus a nightmare, or is it just like they're now awake?
Yeah, I think it's a jolt awake is the question.
Okay.
So
yeah, see, my you know, and every individual, it's hard to answer individual questions because there's so much context, but
yeah,
I would say, going back to something that I talked about earlier, which is this paired association. So you know, think about it. If you fell asleep on the couch watching TV and you wake up in the middle of the night and you're in someone else's bed in a dark room, I mean, that'd be a little bit concerning, right? You jolt awake because it's like, you know, this is not the way I went to sleep. So think about back in the cave days, you know, you check with your environment, you say, you know, is this the way it was when I went to sleep? And if it's not, I better wake up pretty quickly. So my hunch would be to check and see, is everything the same or has something changed? Like, you know, for example, people play music going to sleep. I know you had talked about that, Connie, but for some children, because that music stops when they wake up in the middle of the night and the music's not there anymore, that's enough for them to, you know, jolt awake, because they're like, well, what happened to that music? So we say, like, if you want to use like white noise, like say a fan, just make sure it runs all night. You don't want anything changing in the environment. So if your child's kind of jolting awake, I would check and see, is there anything that's changing from the time they fell asleep to the time they woke up at night? And this also works for treatment, which is kind of exciting. If you teach a child to fall asleep well at bedtime, often night wakings just disappear, which is really exciting. You don't have to do all that extra work. So once they learn how to fall asleep, then when they wake up in the night, and just, you know, those little teeny awakenings where they're checking the environment, they know how to go back to sleep. So often we don't have to treat the night wakings once we've treated the kind of sleep onset issues.
Yeah, that's really, really important, right? And makes so much sense intuitively, Penny. So thank you for that answer. I've got one more question from the chat. Is there any research for people requiring more sleep in the winter months versus summer months? And maybe this goes back to the light or amount of light, or is there anything in that's been done in that area?
Yeah, there's definitely more sleep problems when there's not, you know, when we have different amounts of light. So, you know, as we move north and we don't have like light in the morning, that can definitely cause sleep problems, because melatonin is, you know, impacted by light. Their circadian clock is impacted by melatonin. So light is such a trigger for our sleep that, yeah, it could definitely impact it. I don't know of any research, maybe other people do, like in Canada, like whether it would really make a difference from summer to winter. Definitely makes difference in mood. So my guess is probably. I have to look into that, but I know that definitely when we move quite a bit more north, we see some more sleep difficulties.
Yeah, maybe that's an area that needs to be looked at as well. There's one more. Okay, there's a couple more questions that they keep coming in, so I'll just I'll limit it to the next couple, and then close up by asking the panelists to their final comments. But any suggestions for someone or for a child who's had a bad experience with choking at night, and these issues have led to fears at bedtime and anxiety and more OCD-like behaviors? Is there any? I know that's it's quite specific actually, but I guess it leads to the idea of fear, like the idea of alleviating fear at bedtime, which I think a lot of our kids have those, whatever their fears are, whatever it's related to, it's around the fear factor. Is anybody?
I think the main piece that I would say is that you have to treat the fear at a time different than bedtime, right? That's really important. So you can't really address and kind of work through fear just before you go to sleep, because it's going to trigger not sleeping, right? So, you're going to want to do some desensitization and some anxiety and relaxation therapy during the daytime hours. And once a child learns how to do those in the daytime hours, then you start applying them to the nighttime hours. So, I would, like, there are psychologists that could help work out a plan with how to deal with like a choking phobia, and they would probably start with doing that like in the daytime, and then once the child knows how to relax and to kind of deal with that anxiety, then you'd apply it at nighttime. One of a more simple kind of solution or problem that we often see are fears, like you said, Connie, when going to bed. A lot of times we're busy, parents are busy, kids are busy all day, and you finally get the child's in bed, and all of a sudden all the worries come out from the day, right? My friend said this at school, or I had a conflict with my teacher. Like, it all comes out at bedtime, which is like the worst time for it to come out. So, having a time earlier in the day that you set aside for discussing kind of like problems of the day, and then maybe even having like a worry box at bedtime. So if the child raises a worry, you write it down, put it in the box, and say, tomorrow during our problem time talk, we'll talk about it then, but bedtime is for relaxing. And trying to keep it positive and relaxing going to bed.
Well, thank you so much for answering those very practical questions, and I'm sure that there are many more from our audience that are really when you talk about sleep, it's sometimes you just want to get to the tell me what to do, because you can reach those points of needing that practical help. And I know that Carla's putting in the chat some resources for sleep, particularly Penny's Better Nights, Better Days. I want to close by, before I thank the panelists, I want to know from all of the panelists your final thoughts on the study, where and what's exciting to you, what the next steps are, what do you want to leave with our audience in terms of your feelings about these results and where they're going to lead us? Patrick, can I call upon you?
Sure, thanks, Connie, and I'll keep it brief, just being mindful of time, but
Yep.
just really acknowledging, the value of the team-based science approach, the value of different programs coming together to answer a question like this to this magnitude with this level of data and results, I think really helps drive the field forward. And like you also mentioned too, Connie, it's, sleep issues don't stop at diagnosis, they continue on, and the relationship with symptoms of anxiety and depression, quality of life. We want families to be mindful of that sleep could be one of the reasons why that these symptoms are occurring. So being mindful of that and going back to physicians and clinicians to ask these questions.
Well, thank you so much, Patrick. Andrea, your final thoughts?
Thank you, Connie, and thank you, everybody. I think it's been a very engaging and fruitful discussion. I think this enhances the need for a multidisciplinary approach for these patients and the families in general. Children with NDDs, and I can speak from my own experience, especially with epilepsy. We know that there are so many factors affecting sleep, and we know that the sleep affects epilepsy, and it's almost like a snowball. So I think this could be the start of advocating work to increase access, to promote multidisciplinary teams, to introduce or invest in technology to address sleep issues from the psychological perspective, from the clinical perspective, from the social perspective, and so on. So I think this is a very important first step, and I'm so excited to see how many families join. And we are mindful that we were not able to answer every specific question, but hopefully this would set the stage to a way broader outcome in terms of how can we translate this into practice.
Thank you so much for that, Andrea. I'm going to ask Stelios for your final thoughts.
Thanks, Connie. What an interesting conversation. My mentor at McMaster University for years has been talking to me about what he calls the potentially modifiable factors, right? So in my opinion, and based on our conversation today, sleep may be one of those potentially modifiable factors in our lives. And now that we have evidence that sleep is not just sleep, it actually affects other areas and other domains in our life, I think highlighting the importance of resources for interventions, but also for capacity and training. Penny talked about the lack of expertise in our country when it comes to sleep. So using the evidence to advocate for better supports, better services, and capacity and training for this potentially modifiable and very important factor in our life called sleep.
Thank you so much, Stelios. I mean, it really speaks to the notion of the impact that research studies like these can have and be translated and used in those ways, like using the evidence for training capacity, for advocacy. It's wonderful, and I think that we need to take this show on the road, so to speak, to get it out there. And lastly, Penny, I'm going to call upon you, and then I'm going to close it up here. Penny, what final thoughts?
Maybe I could just share a little bit about our Better Nights, Better Days program, because I did see some questions about that. So maybe if you could just go to that slide. So we are running a study evaluating how to help people sleep better during the COVID context, because stress obviously leads to sleep difficulties. And we have found that for a sizable proportion of the population, they are sleeping worse during the COVID crisis. And interestingly, our research showed that it's even parents are sleeping worse. So the kids a little bit more, but parents a lot more, because I think that they're bearing a lot of, especially moms, are bearing a lot of the stress associated with COVID and working at home and raising children, and it's very complex. So we decided through CIHR funding, we are offering the Better Nights, Better Days program to families from across Canada. There's no randomization, so everybody gets the program. You don't have to wait for to get into the waitlist group or what have you. And so anybody's interested, it really goes through those steps that I told you about. So, teaching about sleep, about healthy sleep habits, and then behavioral strategies. And so if you're interested, please apply. The other thing I'd like to kind of, end on for me is that I'd love to see sleep become right up there with like physical activity and eating well. It's really like the foundation of healthy daytime behavior. That's why I like Better Nights, Better Days, right? If you have better nights, you have better days. And I think it kind of says that whole piece. And obviously, if you're rested, you're well rested, you're going to do better during the day. You're going to do better with your interventions, with your education, with your socialization, with your behavior. And so it really needs to be prioritized. And I think people are getting that. And recently, Canadian Institute of Health Research has put a granting opportunity forward to look at insomnia across the lifespan across Canada. So there'll be some research coming out with this as a really focus. And so I think that's really exciting. I think we're going to see a lot of work on sleep in the next decade. So I'm really excited to be part of that. And I think obviously by how many families and parents are on the line, everybody agrees that it's something we need to kind of help our kids with. So.
And well said, Penny, because we need to really stress the importance of sleep in our lives, and particular in our lives with our kids with NDDs, and how we can help them and help them achieve more success in the future if we know that we've helped them to sleep. So with that, I really want to thank our panelists today for the engaging discussion, and I want to ask that all the attendees please fill out the feedback form. There's an evaluation form that I think Carlos put in the chat, so please do that. We've also got a public talk coming up on November 22nd on your brain on food, and the link will be in the chat, so you can attend that as well. And for any other programs on for OBI, please visit the OBI website for more information. But with that, I want to again thank our esteemed panelists, and really looking forward to hearing more about the work that you're all doing and the impact that it's having, and where what we can learn and help other people with who are really struggling with these issues. So thank you again, and thank you everyone for attending, and have a nice evening, everyone. Thank you so much.
Thank you.
Bye.
Thank you. Thanks, Connie.
Bye.